This video shows the case of an arthroscopic decompression of a posterior knee cyst causing vascular compromise. The patient in this case is a relatively healthy 65-year-old male with a chief complaint of posterior right leg pain that radiates distally towards the ankle. The patient enjoys to walk about 3 to 4 miles a day, but recently, the past few months, he's been unable to walk more than a few blocks due to his pain. He was referred to us after he was evaluated by the Vascular Surgery Service, and he was told that his symptoms were related to compression of the popliteal artery due to a large posterior knee cyst. Patient has seen interventional radiology for attempted ultrasound-guided aspiration of the cyst, but due to the viscosity, the radiologist did not think they would be able to successfully aspirate it. He was offered open cyst excision via posterior approach and also a total knee arthroplasty by other surgeons, but the patient refused. He came to our practice looking for a less invasive treatment. On exam, he has decreased knee range of motion with an obvious posterior mass. He has no palpable pulses in the foot on the affected side, but they are Dopplerable. He also has decreased ABIs on the affected side. His foot is warm and well perfused with brisk capillary refill. His contralateral limb has a normal vascular exam. X-rays show osteoarthritis of the right knee, yet the patient denies any significant knee pain at this point. MRI of the knee shows a multiseptated cyst arising from the posterior knee measuring about 6 by 4 centimeters as shown here on the T2 sagittal images, with significant displacement and compression of the popliteal vessels. The T2 axial images also show the impressive cyst, which lies somewhat lateral to the medial gastroc and is more central than what would be expected of a classic Baker's cyst. We believe this represented more of a ganglion cyst than a classic Baker's. There is no evidence of enhancement after administration of IV contrast. Given the patient's vascular compression as manifested by his claudication symptoms and diminished ABIs and pulse examination, and his unwillingness to undergo an open operation, a thorough discussion was had with the patient regarding arthroscopic excision. The decision was made to proceed with arthroscopic excision with the patient aware that cyst recurrence is a possibility. Standard anterolateral and anteromedial arthroscopic portals were made, and diagnostic arthroscopy was performed. Access to the posterior compartment of the knee was needed for cyst decompression. Due to the arthritis, there were considerable osteophytes in the notch that impeded our access. Here, viewing from a standard anterolateral portal with a 30-degree arthroscope, an arthroscopic shaver and a radiofrequency ablation device were used from the anteromedial portal to remove synovium and expose the osteophytes along the medial wall. A 5 mm arthroscopic burr was then utilized from the anteromedial portal to remove bone along the medial wall to create a path and access to the posterior compartment. Part of the medial tibial spine was also burred down for access. Once a path was created, a transpatellar tendon Gilchrist portal was made in order to introduce the arthroscope to the posterior compartment of the knee. Now we are viewing from the transpatellar Gilchrist portal with a standard 30-degree arthroscope, looking at the posterior capsule. A posterior medial portal was created, and a shaver is utilized from this posterior medial portal to shave soft tissue and identify the posterior cyst. As we get closer to the cyst, we can see yellow cystic fluid appear. This confirms we are in the appropriate area. Next, a 70-degree arthroscope was introduced through the Gilchrist portal in order to get a different view, as the opening of the cyst was relatively inferior. An arthroscopic tissue grasper was introduced from the posterior medial portal in order to send tissue for pathology. Manual digital pressure is applied to the posterior aspect of the knee in order to express cystic material into the joint and onto the grasper. This manual pressure also aids in decompression of the cyst, as you can see the yellow cystic fluid being expressed. After the cyst is decompressed, a shaver is used from the posterior medial portal and driven into the cyst to debride the cyst wall. Finally, the 70-degree arthroscope is introduced through the posterior medial portal and driven into the cyst to ensure complete decompression. Postoperatively, the patient had improved knee range of motion as well as an improved vascular exam to palpable pulses and a normal ABI.